Good afternoon and welcome to a Wired quick chat from the Initiative in Computational Humanities, Arts, and Social Sciences through the Faculty of Computing and Data Sciences at Boston University. Today we'll be hearing from Dr. Brenda Heaton. Dr. Heaton holds joint appointments in the schools of dental medicine and public health. Her NIH-funded work applies complex systems science methods, both social network analysis and agent-based modeling, to understand the underlying mechanisms responsible for generating the population distributions of oral health. She has active data collection initiatives within the public housing communities of Boston to understand the role of social networks and behavioral risk factors for chronic disease. She has funding to develop agent-based models of early childhood caries, within which she conducts experimentation to identify promising targets of intervention. Please welcome Dr. Heaton.
Thank you. All right, so teeth. That's what I study. And what you see here is a depiction of what we call early childhood caries. And early childhood caries is a disease that occurs in kids. It's the occurrence of cavities in kids before the age of 6. Kids should not be getting cavities before the age of 6. They are entirely preventable. And what we see in some kids are apple core teeth. This is when their teeth get bombed out, and you can see it in the second to last on the bottom right. And this is very painful. It causes infection. It can lead to hospitalization. These kids have to go into the hospital operating room to have their teeth removed and replaced. And that's the problem that I'm trying to address, is early childhood caries. It's useful to review how cavities happen. Is there anybody here who has not had a cavity? Awesome, amazing. We have 2 people here who have not had cavities. So for those of you who have had cavities, this is how cavities happen. You have to have plaque or bacteria. Okay, that bacteria feeds on carbohydrates. So when you're eating carbohydrates, that bacteria in your mouth, which is an infectious condition, so the bacteria is passed typically from mother to child. So if you can go with a low bacterial load in your mouth through childhood, you can make it to adulthood without ever having a cavity. Okay? And so kids are not born with this bacteria. It's passed to them. And when you have this bacteria that can feed on carbohydrates, it creates acid. And that acid is what eats away at the tooth and causes a cavity. So how do you get from the occurrence of a single cavity to what we're seeing here in the left? Well, you have a dynamic process that's occurring in the mouth. So you have teeth that are sound, meaning they have no cavities, and they're progressing to decay. And then once you have decay in the mouth, it actually increases your bacterial load. And so you have a higher probability of additional teeth becoming decayed. And so you have a positive feedback loop here of untreated decay, leading to new teeth that were previously sound becoming decayed. You also, when you have a tooth that's decayed, you then are going to go and get it filled, because those cavities can cause pain. If you don't get into the dentist quickly enough, then you can bypass the dentist and go straight to the hospital operating room. And if you're getting preventive services and going to the dentist regularly, they can identify these issues early on and restore those teeth, and therefore reduce this probability of additional decay. So that's what's happening on an individual level. Well, who are the people in the population that are getting these rampant caries? Well, this is a social disparity that exists in the population. So you can see here, this is from 1999 to 2004 NHANES data, the National Health and Nutrition Examination Survey. And these patterns persist today, even though it's an older slide. So what you can see is that those who are in racial ethnic minorities tend to have higher rates of early childhood caries, and then this differs even further based on your poverty status. So there's certain segments of the population that is getting this disease. Well, what happens when we dissect a population based on those segments of the population that have a higher burden of disease? It means we jump to a focus on the individual. But what we have to remember is that the emergent properties of a group of individuals, so these population patterns or social disparities, they're a result of complex interactions that are happening at multiple levels of the system. And so things that we have to keep in mind is that human behavior, whether you brush your teeth, how much carbohydrates, sugary foods, sugary beverages you're drinking, whether or not you have access to a dentist or can utilize dental services, those behaviors are adaptive and they're dynamic. We also have to remember that individuals are nested in a system of influence and that these population patterns that we're seeing, these social disparities, they emerge from a complex set of factors. So we used an agent-based modeling framework. So now getting into how we're addressing this and trying to study this. We used an agent-based modeling framework. We simulated a hypothetical cohort of 2,500 children that are called agents in this framework. And they were followed for caries development and outcomes between the ages of 3 and 6, or 36 months and 72 months. And the modeled mechanisms that are in this model, they're responsive to feedback, such as the transition probabilities from sound to decayed, from decayed to filled, or missing, and they're sensitive to the amount of untreated decay that exists in the mouth and how long that decay has been present, as well as the prior use of dental services. So if you had gone to the dentist before, when you get a new cavity, you have a higher likelihood of going to the dentist to get it filled. So to estimate the baseline parameters for each child, we fit the model to a large empirical data set, and then to evaluate the disparities, we split the population based on those who had caries at initialization, and we called them high risk or low risk. And then we compared outcomes among high risk and low risk kids with respect to how many teeth they had that were decayed, missing, filled at the end of the model run, so after 72 months. And to test the role of dental care utilization, which I'll get to, well, actually, I'm going to just get to these now. So what's nice about agent-based models is that we can ask what happens when. So we can ask what happens when we intervene on the decay probability from sound to decayed, and what happens when we intervene on the care probability from decayed to restorative care. And we can ask these questions about what happens to the disparities in the population or the population distributions when these things occur. So we did that. We decided to look at a known, effective, preventive intervention. Does everybody know what fluoride is? Okay, we have fluoride in our toothpaste. When you're a kid, you can get fluoride varnish painted on your teeth. If you're as old as I am, you probably had fluoride trays with foam that you sat and had on your teeth in the dentist, and you had to spit it out as it oozed from the trays. Or you had fluoride tablets. Okay, fluoride we know is effective at strengthening the enamel of the teeth and strengthening spots that have been weakened by acid. So it can not only prevent decay, but it can actually reverse early signs of decay. So we said, well, what happens if we introduce fluoride into the population and try to look at different targeting interventions in the population with its impact on caries? And what we saw was that in this baseline scenario, so this is no intervention, this the left-hand heat maps. And then we did high-risk targeting, which means in the population we introduced fluoride interventions only to those who were high risk. And then in random targeting, we just increased access generally to fluoride. So this would be akin to a policy intervention where you would just make access much easier to fluoride. And we've seen that where now kids are getting fluoride varnish in their primary care, child visits. You can go to WIC centers, women, infants, and children centers, and get fluoride varnish. It's really accessible in the population. But what does that do to disparities? So if you look at caries experience, which is the top set of panels, when you target high-risk kids only, you see no impact on population disparities. You're not actually preventing them from ever getting a cavity. And when you increase access to everybody, you actually increase disparities. So your disparities, the gap between those who are high risk and low risk is much higher. And if you look at the burden of decay, so the average number of teeth that are untreated, with the baseline, you get a little bit of improvement with high-risk targeting. Or sorry, you get a little bit of an increase in disparity with high-risk targeting, but you get a real big increase in disparities with random targeting. So why is this? Why are we increasing disparities when we're increasing access to a known preventive intervention? And what it is this model starts at age 3, where people already have disparities. And if you recall the model, we have this untreated decay feedback. So once kids are getting into this untreated decay feedback, the strength of that feedback is too strong to be overcome by the efficacy of fluoride. So what happens when you introduce it into the population is you end up not having an impact on kids who are already in this caries process, but you're keeping those who are already healthy even healthier. Right? The chance that they end up moving on to getting cavities is reduced as well. So you end up seeing this increase in population disparities when you target high risk and when you increase access on a population level. And so this gave us some real insight into what's happening and what's driving the disparities on a population level with respect to this untreated decay feedback. Well, what happens when we intervene on the care probability? So thinking about the strength of this feedback, well, let's just minimize the untreated decay. If we can't do anything about preventing the movement from sound to decayed once they're already in that process, what happens when we speed up the process of kids moving from decay into the dental office and getting things filled? And so what we found was that so this is looking at different outcomes. So the average number of missing teeth per child, the average number of filled teeth, the average number of caries, and then there's a combined metric that looks at untreated decay, missing, and filled teeth. So if we look at the top left, we have the average number of missing teeth. Now, teeth go missing due to caries when they're untreated. All right, so this is kids who have had a cavity for so long that it has become so invasive that they have to go straight to the operating room and have the tooth pulled or pulled at the dentist. And so that's missing due to cavities. And what we can see, the orange is the high-risk kids and the blue is the low-risk kids. And along the x-axis is the probability of going to filled. And when we increase that probability, we can see that we're iteratively increasing it over the model runs, and we see that we can reduce the disparity between high-risk and low-risk kids with respect to missing teeth per kid. And you can see that low risk is just pretty flat because they're never making it to such severe teeth that they have to go missing. Obviously, we're going to increase the disparity with filled teeth because we're filling more teeth now with higher probabilities of treatment. And then with caries, so this is new, like untreated caries, we're also reducing that, but not to the same extent. But if we combine all of those, you can see that just increasing the filled probability to 20%, we're able to have a significant impact on disparities between high-risk and low-risk kids. 12 all the way to a difference of about, well, 3, essentially. And similarly, our results suggest that utilizing care can really improve not only just the disparity, but the population burden of untreated decay. So over here on the left-hand side, you see that if you take the whole population, the average untreated decay is about 1 tooth. And as you increase the filled probability, you're reducing the entire population's untreated decay burden. And then if you look at the disparity between high-risk and low-risk kids, you're going from a difference of 7 teeth being untreated to nearly 0. And when we analyze the model, so we take the model output and we look at things like average time to treatment, if you increase this all the way to 20%, what you see is unrealistic time to treatment. So the average time to treatment from getting a cavity to having it filled was like 1 month. So that's where you have to introduce subject matter expertise to figure out, well, what's realistic? How quickly could we get kids into care? And what would that intervention look like? And what would be necessary for that to happen? Are there enough dental care providers? Are there enough dental care providers that accept patients that are high risk, et cetera? So once you understand these modeled mechanisms in this setting, you can start to ask questions about what the necessary intervention would have to look like to accomplish this. So this is a really simple model. We're only talking about the person and the tooth level, but this untreated decay feedback loop, the strength of that feedback loop is attributable to higher level influences. So we already have biological and individual levels to some degree, but then there's social influences, there's political influences that are going to, you can parse out the strength of that feedback to those levels. And so that's what we're trying to do right now. So we have another iteration of the model to incorporate these higher level influences. And in this case, we're looking at caregiver behaviors as something that would mitigate the sound to decayed probability and the decayed to restorative care probability. And we've also extended this to a population of kids. We went from 3 to 6, where kids started the population with cavities already, to 0 to 6, where we've now simulated the eruption of primary teeth, which was a fun exercise. And now we can see, well, how do we prevent cavities from happening in the first place so that this feedback loop doesn't happen, even when these kids are in what we would call quote unquote high risk situations, where they have low access to dental care. Their behaviors, those what we call cariogenic behaviors, such as high sugary food and beverage consumption, poor oral hygiene, et cetera, might already be high. And so this model, it also utilizes clinical and behavioral data from a longitudinal study of children and their caregivers. So we have data that we can fit to that. And it combines machine learning and subject matter knowledge to parameterize the model. And once we're very close to finalizing that model, and then once we have that model, we can then do experimentation with what if we were to intervene on caregiver behavior. We already know from some machine learning work which behaviors really matter. We've parameterized the model with those behaviors, and now what happens when we intervene on those behaviors. And we're able to do this without enrolling any individuals into our study, paying them, following them, coaxing them to participate over time, et cetera, so we can get a real sense of what is feasible, what's practical, and what's going to have an impact on the outcomes that we're interested in. And our next iteration, where Dr. Gondel comes in, is then placing these caregivers into social networks to be able to understand what social influences may be operating on their behaviors. To summarize, the population patterns and distributions of disease, so disparities or inequities, are emergent properties of a system that produces them. And that's a key thing to remember. And this puts us into a complex situation, and complex issues require complex solutions. And complex system science methods, they provide us with this nuanced opportunity and novel insights into potential solutions. I think I'm exactly at 20 minutes. So, questions? Yeah.
Is resistance to interventions a concern with these models?
can you describe a little bit more what you mean about resistance?
Sure, yeah. So often the higher risk individuals in a society are more resistant to being forced to do something or having some sort of societal influence or intervention on them.
Yeah, so I think I subscribe to the belief that individuals generally want to do what's good, what's right, especially caregivers for their children, and that the resistance may not necessarily come from them as individuals, but it comes from the systems and structures within which they're placed. And so if they don't have the capacity to change, change is really difficult. And so the resistance, I wouldn't say necessarily is an attribute of an individual. Certainly they have values, certainly they have things that motivate them, but all of those are also shaped by the system that they're in. And what's interesting, I'll just share this. I added this slide. So when you focus on the individual, right, the segment of the population that is at highest risk, you tend to focus on that segment and just think, oh, if I just fix that group, I'll be fine, right? So here's a nice little lesson learned. We conducted randomized trials as part of a large early childhood caries collaborative. We did it in public housing here in Boston. We also did it in American Indian children on reservations in Colorado. We used motivational interviewing, which is a behavioral intervention that's been shown to have great success with smokers, which is a very hard behavior to change. And we had both of these trials were totally null. No effect. The primary outcome was on caries, clinical caries, no effect on caries, and no effect on behavior. And it was this experience that spurred us, not after the findings, but in the process of it, realizing that these caregivers are influenced by their social network. And you can't take somebody out of their context, rearrange their behaviors, put them back in, and expect that to stay, right? So it's not that they're individually resistant. They're doing what they can. They're adhering to the whole protocol, right? But it's you put them back in their environment, and there's all of this influence and pressure that is reshaping the work that you've done on an individual level. Does that make sense?
Thank you.
Yeah.
I'm curious, like, if you can go back to the most latest, like, model side, why does those bottom three need to be a agent-based model and not a stock and flow system dynamic model?
It doesn't need to be.
Okay.
Are you talking about like sound to decay to restorative care? Like that could be a compartmental model. Is that what you're saying?
Yeah, basically.
It absolutely could. But the heterogeneity that comes from an agent-based model is so useful in being able to understand what's going on and how things emerge from this group of individuals. You're simplifying things when you put it into like a true like SEIR type model, right? Where you're just saying, okay, a group of people flow into this one, then they flow into that one. But we want to understand what on the heterogeneity in the population by the individuals, right? Why they're having different outcomes. The individuals that are comprising those groups are having different outcomes.
Yeah. Okay. Like you can make 100 bins for every different potential combination of demographic groups.
Yeah, but
or
why
you
would
could just do
that?
an ABM.
Yeah. Any other modelers in the room can correct me if they disagree with my perspective. But you absolutely could do this in different ways. Yeah.
A lot of people are afraid of dentists. Can you locate fear of dentists in this model?
So let's see. Did you catch this one? Where was it? Oh, I had it at the very beginning. Sorry. Here. Did you see this? Is that what's prompting your question? Yeah, so that is, dental care related fear and anxiety is incorporated into, you have this Anderson model of healthcare behavior, which is what this perceived need, predisposing factors, and enabling factors parses those types of behaviors into, and you have anxiety in that model. And so some of the work that I'm doing right now is trying to advance the work that psychologists have done about how do you define dental care-related fear and anxiety. It's multifaceted. It has behavioral attributes, it has like physical attributes, et cetera. How do you take the measurement of that and put it on a population level so that then one thing Neha and I are going to be doing, well, we are doing, is trying to understand how dental care-related fear and anxiety may be a socially transmitted, right? And so I have some qualitative work that's looked at social networks and transfer of dental care-related fear and anxiety from traumatic experiences. And then we're trying to figure out how to quantify that and measure it on a network level and then be able to model it and incorporate it into these models. Yeah, because it's a big deal. Other questions?
The thing you were saying to Gabe's question about how it's the population overall resistance to change rather than individuals. It just made me think of the WASH benefits trial failing. It's a big deal in the international development world. WASH benefits, water sanitation and hygiene intervention, that just completely failed.
Yeah.
It was like potentially similar reasons.
Yeah, you can track the failure of individually focused interventions. There's a whole, like you can actually pull them from the literature and demonstrate that it's due to complex systems. That, you know, the individual-based intervention was not accounting for the complexity. And so, anyway, it's slowly funding bodies in the health world, like National Institutes of Health, and even CDC, they're slowly catching on to these methods and trying to invest money in these methods, because those randomized trials that I had here, they took 6 to 8 years and about $14 million for one. Huge investment. And nobody's using the data that came from them except for me to parameterize models. So it's a waste of money. So there's big opportunity in these types of methods.